The next part, we are going to talk about the kidney damage associated with diabetes. National Health and Nutritional Survey examination was done in from 2005 to 2010. And it showed that patients have reduction of their glomerular filtration rate. 19% of patients have GFRs less than 60. 29% of the patients have urine microalbuminuria or albumin to creatinine ratio over 30. 8.6% of the patients will have both albuminuria and low GFR. Incidence of nephropathy in US have been stable over the years, despite actually our increased risk of increased use of the medications, the statins. We were able to reduce LDL. We were able to use the more of the ACE inhibitors and angiotensin receptor blockers. We achieved slight reduction in the hemoglobin A1C, in improvement of the glycemic control. But again, despite all of that, we were not able to achieve lowering of the incidence of the neuropathy, of the retinopathy, I'm so sorry, nephropathy, which has have been frustrating. So what is the natural history of the neuropathy, of the nephropathy? Stage 1, we actually can see hyperfunction of the nephrons, and it's the beginning of the hypertrophy. So we can see increase in the GFR. Albumin excretion may be increased on that stage, and it may be present at the time of the diagnosis in both type 1 and type 2 patients. In stage 2, this is a silent stage when there is a thickening of the membrane, basal membrane, and GFR would be still normal. Patients may have protein microalbumin, but a lot of the times it will be normal. And it's usually in the first 5 years of the diagnosis of the diabetes. Then patients enter stage 3, which is includes microalbuminuria or GFR beginning to fall. And albumin would be, definition of microalbuminuria would be 30 to 300 milligrams per day. That stage can last anywhere from 6 to 15 years, but again, variable. Stage 4, which is overt diabetes nephropathy, when patients develop macroalbuminuria, which defined as excretion of protein over 300 milligrams per day, and GFR would be further declined. And the stage 5 is the uremic or developing of end-stage renal disease that requires hemo or peritoneal dialysis. Nephropathy is the major risk factor, independent risk factor for diabetes, for cardiovascular disease, and even at the stages of microalbuminuria, it has been shown that it is independent risk factor for cardiovascular disease, myocardial infarction, stroke, and cardiovascular death. Albumin to creatinine ratio can vary on repeat samples. Therefore, we need to do at least 2 to 3 samples to confirm it, because it can vary up to 40% in patients. In the stage of microalbuminuria, it can go into spontaneous remission if we control glucose and blood pressure and lipids. Again, up until now, the blood pressure goal was less than 140/90 in non-diabetes kidney disease and less than 130/80 in patients with proteinuria. And as of yesterday, as I mentioned, it may change and may lower, those threshold could be lower from American Heart Association, again, just released yesterday. Differential diagnosis of non-diabetes causes of the chronic kidney disease are important because we need to rule out other causes. So over 50% of patients with diabetes may have other causes of nephropathy. And some of those would be, need to be suspected if patient had relatively short duration of diabetes, and have severe hypertension or rapid decline in the kidney function. So the conditions to be ruled out are IgA nephropathy, focal segmental glomerulosclerosis, especially suspected in patients with HIV or African American ancestry. In this case, biopsy would be indicated to rule out other conditions. Type 2 diabetes, as we mentioned, so this looked at, so if you look at this diagram, that shows that in type 2 diabetes, it's not only the glycemia that contributes to the development of nephropathy, but other associated conditions such as obesity, hypertension, vascular disease, some of the medication that were used, use of the contrast media for diagnosis of various complications, and causes the reduced kidney function, reduced filtration, irrespective of actually metabolic control, and causes the kidney damage. Again, if patients have recent onset of diabetes and rapid progression, despite either poor or good metabolic control, sudden onset of nephrotic range proteinuria, it's important to rule out other conditions that could be causing the nephropathy. So consider kidney biopsy in this patient to make sure we're not missing other conditions. So just to summarize that, factors contributing to development of diabetes kidney disease would be combination of hemodynamic factors, metabolic factors, and also genetic factors. There were various candidate genes that were looked at for the development of the nephropathy. Familial clustering had been shown in patients with chronic kidney disease and also proteinuria. So it's important to assess glycemic control in all the patients, and it might be difficult in patients who are undergoing kidney replacement therapy such as peritoneal or hemodialysis. So hemoglobin A1C was introduced in clinical practice from 1976 for the first time. Recommendations are different from patients who are undergoing dialysis. Then regular A1C level cannot be followed in those patients for multiple reasons. So there's no good evidence to support actually what's the ideal control should be in patients with significant degree of chronic kidney disease. Hemoglobin A1C can be decreased in patients who are receiving erythropoietin or Epogen, which is most of our patients with significant kidney disease. Vitamin B12 administration, patients who have reticulocytosis or chronic liver disease would take aspirin or vitamin D or vitamin E, would have various hemoglobinopathies, decrease in erythrocyte lifespan. Patients have splenomegaly and higher destruction of the red blood cells. Various drugs, which would be in different antiviral drug and some of the antiviral, antiretroviral medications, and hypertriglyceridemia itself can affect the levels. Specific challenges and diabetes and patient with chronic kidney disease would be actually alteration in glucose metabolism, insulin resistant fluctuating dependent on the time of the day, depending on the day of the dialysis versus pre-dialysis day because of the uremia, so impaired insulin secretion in those patients. There is a decreased insulin degradation and longer half-life of the medications. There's an effect of drug metabolism and dialysis itself. So major studies that were done with nephropathy actually excluded patients with end-stage renal disease. So because of the higher chance of hypoglycemia in these patients, the target for hemoglobin A1C was extended to under 8%, comparing to under 7% in patients without CKD. Treatment of diabetes and the second of CKD, again, as we mentioned, is difficult, but intensive glycemic control is still important, but with a different target of the A1C. Use of the medication should be very cautious because of the effect of the kidney function. From sulfonylurea medications, glipizide can be used. It does not require any of the dose reduction. Glimepiride can be used, but in the lower dose because of the partial metabolism through the kidney. Glyburide is the longest acting sulfonylurea, contraindicated if patients have GFR less than 60. For short-acting secretagogues such as repaglinide, nitaginide, and meglitinide, we can use those with a patient of kidney disease, but again, with caution and dose reduction needed. Pioglitazone, dose reduction not needed, but be careful using in dialysis patients, and usually we do not recommend using higher dose than 30 milligrams per day. Medications such as acarbose or meglitol, using with caution if GFR is decreased under 60, and contraindicated if GFR is less than 30. DPP-4 inhibitors can be used, but the safest medication would be linagliptin or Tradjenta. It's not kidney metabolized and can be used in patients with who are on dialysis. So the new class of drug, which being studies, being in patients with chronic disease, not yet approved in patients with chronic disease, but again, there are several studies that are undergoing. Dapagliflozin or Invokana, avoid to use this drug if, dapagliflozin or Farxiga, avoid using this drug if GFR is less than 60. Canagliflozin or Invokana can be used if GFR is over 60, either dose 100 or 300 milligrams. Avoid if GFR is less than 45. Empagliflozin or Jardiance, the same indication, avoiding if GFR is under 45. Use of the blockade of the angiotensin receptor blockade or aldosterone gradient blockade. So there were multiple trials that had been shown that there is an improvement and delay in the progression of the kidney disease with the use of those medications. And I've listed here some of the major trials that had been studied. So several studies using the angiotensin receptor blockers showed that there was a reduction of the time to nephropathy by 39 and 70%, which was dose dependent. Another study with irbesartan showed that patients with increased creatinine showed that mortality was reduced by 20% versus placebo, and 23% with the amlodipine use. Microalbuminuria was reduced also in patients with the use of valsartan comparing to amlodipine, 44% in valsartan group and 8% in amlodipine group. So it's important to initiate that treatment and to follow patients closely. Use of either ACE inhibitors or angiotensin receptor blocker showed reduction in risk of rapid progression, decline in the GFR, and kidney failure and death. And you can see the result of effect of the ramipril comparing with ramipril with amlodipine, or ramipril versus metoprolol, losartan versus placebo, and irbesartan versus amlodipine or versus the placebo effect. So one of the important conditions that needed to be mentioned is the diabetes autonomic neuropathy. And I'm sorry, I'm running a little bit over time. So let me know if you want to stop or if we can finish the slides. So diabetes autonomic neuropathy can affect both para and sympathetic neural system, or both. Clinical manifestations would be hypoglycemia awareness, resting tachycardia, which is one of the earliest, orthostatic hypotension, gastroparesis, which is debilitating condition, constipation or diarrhea, fecal incontinence, erectile dysfunction, neurogenic bladder, increased sweating. Cardiac autonomic neuropathy is a devastating condition. Prevalence increases with the diabetes duration. It had been shown that 30% of patients after 20 years of type 1 diabetes may develop this condition, and up to 60% of patients with type 2 diabetes actually develop fairly early after 15 years of duration. And it could be present in young individuals as well. And it's independent risk factor for cardiovascular mortality, arrhythmia, silent ischemia, and actually silent death. So here you can see the clinical manifestations of diabetes, autonomic neuropathy, which includes, again, cardiovascular, gastrointestinal, sexual dysfunction, bladder dysfunction, and pseudomotor dysfunction. Dcct and edic, the trials that we've talked about, again showed that glycemic control after 30 years of follow-up in patients with type 1 diabetes still maintained 47% and 30% after 20 years reduction of cardiovascular disease. The effect was lower by 30 years, but still persist reduction in cardiovascular disease even with the first few years of being tightly controlled with diabetes.